Good morning. Good morning.
Good morning. Good morning.
It's a great morning. Looks like we might get a few drops of rain. That makes it even better. Welcome to Charles Drew University of Medical and Science this morning. Joining us for our symposium on smoking cessation, detrimental effects, whatever else we can push in this 2 hours that we want to share with you. A couple of housekeeping things. There are 2 restrooms just outside in the lobby to the left. They're unisex, so you could go in either one now. They finally changed, and we should always have a long line for the women. You know how that goes, girls. And we're not supposed to be eating and drinking in here, so let's respect what the university asked. They're trying to keep the auditorium nice. So, those of you who are wanting to collect CEUs for this symposium, make sure that you've signed in outside. The evaluation form is on the back of the first page of your handout. That will need to be submitted, and then you need to sign out again. And then they'll send you your CEUs. Make sure that they can read your name, your email address, or whatever it is that they ask for on the sign-in sheet clearly. And for the rest of you who are not asking for CEUs, we're also asking you to complete the evaluation. And in the comments section, any general comments that you may have about the symposium, what you'd like most, what we can improve on for next time, we'd appreciate that.
No, but they just pick up their CE certificate when they leave.
Okay, great. They're outside. All righty. So we're on time. So we're going to get started with our first presenter, our keynote speaker this morning.
I want to get rid of this thing right here.
Okay. While he's doing that, I want to introduce you to Dr. Brian Hurley. He's an addiction psychiatrist and medical director for co-occurring disorder services at the Los Angeles County Department of Mental Health. And this is a new position from what I understand. And, you know, following along with those of you who've been following the whole thing with integrated care and the Affordable Care Act and moving more towards that, new position to start addressing those issues. He's an assistant professor of addiction medicine in the Department of Family Medicine at the UCLA David Geffen School of Medicine. And Dr. Hurley is also currently the treasurer of the American Society of Addiction Medicine and co-chairs the Los Angeles County Department of Health Services Substance Use Disorders, Department of Health Services Substance Use Disorder Work Group, and the Safe Med LA Medication for Addiction Treatment Action Team. So we got a heavy hitter here in terms of substance use disorders, and we're really looking forward to hearing from him. Additionally, Dr. Hurley is a member of the Motivational Interviewing Network of Trainers, provides training in motivational interviewing across the United States. He completed a Robert Wood Johnson Foundation Clinical Scholars Program at UCLA and was previously a Veterans Administration National Quality Scholar at the VA. So we even have VA expertise. He completed a fellowship program in addiction psychiatry at New York University School of Medicine. He completed residency training at the Massachusetts General Hospital and McLean Hospital, where he was chief resident in addiction psychiatry. So help me welcome Dr. Hurley.
Good afternoon.
Good afternoon.
Is everyone able to hear me?
Yes.
All right. So first, thanks for having me. Actually, it was the first time I've been privileged to speak here at Charles Drew University, so thank you for such a warm welcome. I figured what we could cover during the next half an hour or so is to talk about smoking and smoking cessation in people with mental health and substance use disorders, because in the United States, smoking is not evenly distributed among all populations. Not all communities smoke at the same rate. We know in the United States overall, smoking rates, the prevalence of smoking is well under 20%. I think we're looking at sort of 12% prevalence now across the United States. And among youth, there's far more youth starting to smoke electronic cigarettes than smoking conventional tobacco cigarettes. In fact, more youth are starting to smoke cannabis products than to smoke conventional tobacco cigarettes. It's just sort of a big frame shift if you think about the way that, well, substances are used in society. So I'm going to focus most of my comments about smoking cessation in those with mental health and substance use disorders where smoking prevalence remains much higher than among sort of the general population. And I have no conflicts of interest to disclose. My job is with the county. I don't work for any pharmaceutical company, so I'm not here on behalf of any, any for-profit agency that's looking to try to sell anything. So what do we know about smoking in people with mental illness? And let me just be clear. For the purpose of this slide, mental illness is defined as everything that's in the, psychiatric manual other than substance use disorders. So this is for people with mental illness and not substance use disorders. We know that people with tobacco use disorder, but at the time nicotine dependence, made up 7% of the population but smoke over 1/3 of all cigarettes in the United States, and that mood, anxiety, personality, and illicit substance use disorders are associated with a significant increase of persistent nicotine or tobacco use disorder. So this chart just kind of goes over that those in mental health treatment smoke at much higher rates than those without mental health treatment. If you then look, okay, what about people who are in substance use disorder treatment? People who go to methadone clinics, residential treatment programs, outpatient addiction treatment programs. What about those folks? And we know that actually they have some of the highest smoking rates of any population in the United States. Certainly higher than compared to sort of the general population, which is that lower red line. For people with a particular mental health condition, schizophrenia, we see really high what's called concordance, that people with schizophrenia smoke an awful lot more than people without schizophrenia. And it's, some authors have said that 80% of people with schizophrenia smoke tobacco cigarettes. And if you actually sit people with schizophrenia down and look at how do they smoke, you know that they smoke more, the time between puffs is shorter by about 6.5 seconds. So not only are they smoking more people are smokers than not smokers, but when they smoke, they're taking more drag out of each cigarette as compared with people without schizophrenia. And so not only are there more puffs per cigarette, but there's a greater drag on the cigarette. So there's thought to actually be something around the way that nicotine affects the brains of people with schizophrenia that's thought to be why people with schizophrenia are at such high risk of smoking. And this is a courtesy of Jill Williams of New Jersey. So she then looked at, okay, well, what if we just looked at serious psychological distress? And there's a scale of symptoms of, stress, anxiety, psychosis, and so forth. And for people that have more symptoms, you see more cigarettes, more people reporting past month cigarette use. That is, cigarettes are actually, people report that they're helpful, right? People don't smoke because they want to have all of the negative consequences. People smoke because they describe it as helpful, right? That it helps reduce stress. It helps me deal with anxiety. It helps me deal with all these things. And actually, if you think about the life of somebody that smokes, it's really easy for somebody like me to come up here and say, oh, well, just do smoking cessation. All you have to do is not smoke. But what it requires you is to actually unlearn how you smoke, because smoking is a learning process. So what happens is you learn that when you wake up, you're a nicotine withdrawal. So if you're a nicotine withdrawal, you have a cigarette. And you learn that when you go to work, the first thing you do before you walk in is to have a cigarette. And then you learn that when you go on a break, the next thing you do is you have a cigarette. Or if you get stressed out, you have a cigarette. Or if you go on your lunch break, you have a cigarette. Or if you want to hang out with your friends, you go in a circle of people who are having cigarettes. If you want to, you want to celebrate, you have a cigarette. You want to finish your shift, you have a cigarette. You get home, you have a cigarette. Before you go to bed, you have a cigarette. You have to. So what actual smoking cessation requires is people to unlearn all of those things, right? You have to learn how to wake up and not smoke, and go to work and not smoke, and take a break and not smoke, and hang out with your friends and not smoke, be able to tolerate stress and not smoke, or go to bed and not smoke. And it requires, actually, you have to relearn how to not smoke now in all of those situations, which is actually a relatively complex process, right? And you can imagine people with mental illnesses oftentimes have a harder time unlearning a process that has become really quite ingrained. For people that take psychiatric medicines, we know that smoking tobacco cigarettes changes the way that your liver metabolizes some of these medicines. And it's actually not the nicotine itself that's thought to do that. It's that when you ignite tobacco, and all of the, what are called polycyclic aromatic hydrocarbons, those are the things that get into your DNA and cause cancer. That's the sort of the part of the cigarette smoke that's pretty bad for you. Your liver does its best to clean it up. But when it does that, the polycyclic aromatic hydrocarbons induce your liver to eat through all of your psychiatric meds actually much faster than non-smokers. And so what we see is in mental health treatment, people who've been stable on their meds, if they change their smoking status, let's say they go from non-smoking to smoking, or they go from smoking to non-smoking, you might have to increase or decrease the dose of somebody's psychiatric medicines if you want them to keep stable, right? And you see this actually a lot in people who are in prolonged involuntary hospitalizations who get stable on a set of meds, and they leave, and it's oftentimes thought, well, you know, if people leave, maybe they're not taking their meds. Perhaps, but one of the things that might also be going on is that they changed their smoking status. They went from not smoking to smoking. Now all of a sudden the same meds that had stabilized them are no longer sufficient, and you have to know how to sort of respond to that. So here's actually a list. I don't expect everyone to sort of memorize all these lists of these medicines, but here's a list of some commonly used psychiatric medicines, all of which are affected by a particular enzyme in the liver that is responsible for metabolizing these medicines. Okay, so there's a bunch of surveys that get done, given that we know that people with mental illness and people with substance use disorders smoke at much higher rates than the general population. Wouldn't it be logical that people in mental health treatment and people in addiction treatment are delivered, how do I put this politely, are aggressively offered treatment, right? Like, wouldn't it make sense that you would want to combine a high-intensity disorder treatment with mental health and substance use disorder treatment because that's where the need is? And so there's a bunch of investigators that went in and looked. What is the rate of smoking cessation in community mental health? They looked at the records, they talked to psychiatrists, and did a bunch of surveys. And they found tobacco use disorder was documented in less than 2% of the mental health records. Less than 2%. We know that the prevalence in people with schizophrenia is somewhere near 80%, and the overall prevalence hovers somewhere between 40 and 50%, depending on the population. So 2% of the records actually document tobacco use disorder. That is, well, wrong. I mean, that's just not that's not an accurate, diagnostically accurate. Psychiatrists treat tobacco use disorder in less than 2% of our outpatient practices and have the lowest awareness of quit lines and state tobacco services compared to almost every other physician. And in fact, smoking cessation is oftentimes seen as the purview of primary care rather than being in the purview of community mental health, even though there's much more smokers in community mental health than in general primary care. And less than 30% of state psychiatric hospitals offer smoking cessation services, and less than half of outpatient substance abuse treatment programs offer smoking cessation counseling or pharmacology. So there's a big, what I'm pointing out here is the gap, right? The gap between the need and between the service delivery. This is sort of more research. This is Psychiatric Services, a prospective evaluation of smoking status in quit attempts over 11 years in 174 community outpatients in a longitudinal study. 3/4 of the population made at least one quit attempt over 11 years. So it's not like people in community mental health don't want to not smoke, right? Like people, I've yet to see, I work at West Central, which is kind of up the way a bit in Crenshaw. And when I'm there, I have yet to meet a patient that's fully enthusiastic about smoking. You know, I've yet to meet anybody that says, yes, I smoke, I love smoking, I love everything about smoking, and if I could afford to, I'd smoke all day, every day, right? What you see instead are people that are like, I know this is bad for me. I know this is something that's not helpful. There's things about smoking I like. There's ambivalence, right? There's things about smoking I like, but there's things about smoking I don't like. And if I could quit, I would. And you see that all the time. And that bears out in the research. But because we have these people that are thinking about smoking, they're sort of contemplative around smoking, maybe they're taking action, maybe they're not taking action. If we don't jump on every quit attempt, it's a huge missed opportunity in the field. When I give this talk, I give this talk to psychiatrists, and I want to be sure that every psychiatrist in California is aware of the state quit line, right, 1-800-NO-BUTS. It has a website, a specialized program for all kinds of smokers, including people with mental illness, people with pregnancy, in the community. This is a big resource that I want to make sure that everyone's aware of because it offers a lot of services at no cost. certainly to Medi-Cal beneficiaries, but can also help people who are not eligible for insurance. So what do we know about cravings and relapse smoking? Well, in an internet sample survey, 400 smokers with either 1 to 10 years of abstinence endorsed triggers of being depressed mood, drinking alcohol, seeing somebody smoking, and being where you used to smoke, right? People, places, and things, the most common triggers we know for relapse. Psychiatrists and mental health clinicians can address people's depressed mood. Substance use treatment programs can address alcohol use. That is, the idea that we wouldn't want to integrate smoking cessation services into behavioral health is anathema, because we know that many of the triggers are actually managed by people that provide behavioral health treatment. Smoking cessation, so one of the things that I also get told is that, well, you know, I could do smoking cessation treatment, but my patients can't tolerate it. I don't want to stress them out. I don't want to make them more depressed. I don't want, there's all kinds of good reasons why I wouldn't want to do that. This article, BMJ 2014, looked at smoking cessation during mental health treatment. Did it destabilize people, right? Like, did trying to provide smoking cessation cause a rash of psychiatric hospitalizations? I mean, that was sort of one of the things they were looking at. And what they found is once you got people through smoking cessation, once you got people to initiate abstinence and get through acute withdrawal and whatever they were going to manage, it actually improved their depression, anxiety, and stress. In fact, improved their mood and quality of life more effectively than antidepressants. So if you think about that, most community mental health centers, you come in complaining of anxiety or depression, one of the things that you'll be evaluated for by a prescribing clinician is a medication. And antidepressants are the first line for anxiety and depression. And I will still offer patients those things, but I think I would be hugely remiss if I didn't offer that in concert with smoking cessation, which is a really powerful way of helping address people's, you know, depression, anxiety, and stress in the first place. So this is a guy. Does anyone know his name? A picture of, does anyone know who this is a picture of? Yeah, Bill W. Bill W. And does anyone know what Bill W. did in his life that he's most known for? He's the founder of Alcoholics Anonymous. Bill W. is the founder of Alcoholics Anonymous. Alcoholics Anonymous is a community-based, peer-driven program that helps people stop drinking. And in fact, has been so successful that that is, I would say, a dominant model in the addiction treatment field. It's not the only model, but it's a dominant model in the addiction treatment field. And hundreds of thousands of probably now millions of people across the world have now reduced or eliminated their drinking due to the help of Alcoholics Anonymous, due to the work of this guy. So it's very powerful. But does anyone know how Bill W. died? How did Bill Wilson die? He died of emphysema because he was a lifelong smoker. And if you've ever been to an AA meeting, what happens at AA meeting? I mean, people talk. I mean, you know, there's the talking part, right? But there's smoking and coffee, right? Smoking and coffee, those are two things. There's coffee and there's cigarettes, and that's what's at AA meetings. So the irony to me is here you have a founder of one of the major treatment paradigms that we use in the substance abuse treatment field. And he himself perished due to smoking-related illness. And that highlights the big difference between, you know, we really want to focus on intoxicants like alcohol, but we sort of permit and, in fact, in some ways encourage by just creating a setting where cigarettes are so accepted, people to use another type of intoxicant, which in this case is nicotine. So the majority of patients enrolled in substance use disorder treatment also smoke tobacco. And there's this idea of, well, maybe it makes sense to do one drug at a time. Like, we'll address your alcohol now, and then when you're ready, we'll stop smoking. There's actually no evidence that that is true. You can stop all things at the same time. And in fact, there's some evidence to support that actually that helps. People that keep smoking actually do have poor treatment outcomes compared to people that are able to stop smoking. And without smoking cessation treatment, substance use disorder treatment, like going to a 12-step meeting, does not help you stop smoking, right, on its own. Like, you have to have smoking cessation services integrated into substance use disorder treatment. So there was a meta-analysis looking at smoking cessation interventions in individuals with a substance use disorder. And there was a 25% increase in long-term abstinence from alcohol and illicit drugs when people were able to participate in, were actually able to stop smoking. That is, smoking cessation interventions during treatment enhance long-term sobriety from the substance of choice, not just from the tobacco use, but from their substance of choice. Smoking cessation treatment does not impair people's primary substance abuse problem, and again, enhances substance use disorder treatment outcomes. People who smoke cigarettes tend to be more stress reactive. Particularly during nicotine abstinence, people have a hard time resisting smoking. And that first cigarette that you have when you're in the middle of nicotine withdrawal tastes great, I'm told. Right, for people who really when you sort of are craving a cigarette, that first cigarette actually talks about the intensification of smoking pleasure. So there's all of these strategies that we have to be able to get people through smoking cessation. There's telephone counseling, brief interventions, there's clinical models, primary versus behavioral health, and then one of the things that we can offer in behavioral health is a tailored approach. As a psychiatrist, I see my patients for longer visits than most primary care doctors do. My visits are face-to-face. I am able to provide, smoking cessation services, particularly medicines, to help support smoking cessation, but also, counseling and referrals to places where people go to sort of unlearn, to do that process of unlearning how to make smoking a part of their life. And there was an article that was just published in the New England Journal looking at, so what do we know about the efficacy of these different approaches? So I'm sort of mentioning these are all things we could do, but how well do these work? Well, so this was a trial that looked at, how does usual care, that is people that just show up to their doctor, and in this case this was a community health setting. So they just go to their primary care doctor, how many of them stop smoking? If you look at usual care, which is on your left, there we go, on the bar on your left, one person in the usual care arm stops smoking, just on their own. But nobody else stopped smoking of the 6,000 people that had been randomized in the study. So one person stopped smoking. And if you give people free smoking cessation aids, so you give people telephone counseling, you give people medicines for smoking cessation, and you make all of that stuff free, it increases it, depending on whether which analysis you want, from none to a little bit. It's not statistically significantly different, right? So free cessation aids did not beat usual care in terms of the statistics, but it looked like it trended that way. And then there was this hypothesis of, what if you give people e-cigarettes? Do e-cigarettes help people stop smoking, right? Because e-cigarettes don't involve burning a leaf, a dried leaf. It involves inhaling polyethylene glycol that's with aerosolized nicotine. So, does that help people quit smoking? And interestingly, no. There was no significant difference between usual care and free e-cigarettes. What did work? Financial incentives. That actually offering people a deposit into their account if they stopped smoking and stayed stopped smoking, and comparing that with, part of their assessment was these carbon monoxide monitors to validate whether people were smoking or not. That seemed to make a big difference. And then if you look at the cost, what is the cost of offering usual care versus free cessation aids versus offering people financial incentives, right? Clearly, offering people financial incentives costs more than doing usual care, right? That's associated with increased cost. But if you then want to divide that, okay, but what did that cost divided by the number of successful quits? That is, what is the cost per successful quit? Actually, you see the cost per successful quit go way down the more incentives you offer, interestingly, right? That seems to be sort of a powerful model. Okay, so in case it's not obvious, I think behavioral health should take the lead in treating tobacco use disorder in people with mental health and substance use disorders. Tobacco use disorders in the Diagnostic Statistic Manual, which is the sort of book of all of the diagnosis in mental health. People, whether you're talking about behavioral health clinicians or, even I would say people in, peers and 12-step groups, I think have knowledge about addiction and can apply that knowledge to the treatment of tobacco use disorder. People in behavioral health have longer, more treatment sessions, are experts in psychosocial treatment, and there's a huge patient need, and it actually helps our patients get better. It helps reduce anxiety, it helps reduce depression, and it helps people stay sober longer. The readiness to quit is not different. If you look at the general population versus general psychiatric outpatients versus people who are depressed versus people who are inpatients versus people in methadone clinic, there's not a significant difference between people's real readiness to quit. So people, smokers, people with tobacco use disorder, with mental illnesses or experiencing an addictive disorder are just as ready to quit smoking as in the general population. Sometimes these individuals need additional support, right, to help them cope with stress, to be able to sort of help people through. So it's not the same in terms of like the intensity of service that's needed, but I do think if we just sort of say, well, this population isn't ready to quit, the evidence does not support that. There is yet to be a smoking population that has not at least thought about quitting smoking. People with behavioral health conditions are motivated to quit. Again, another study from 2009 looking at more than half of all smokers are contemplating quitting within the next 6 months. And then, so I just want to cover really briefly, integrated care begins with the 5 A's. This is the ask, assist, advise, assist, arrange model of talking to people about smoking cessation. I personally use something called frames, which is I offer people feedback. I remind them that smoking is their responsibility. I offer my advice and a menu of options about things that would be helpful. But I also say, look, unlearning smoking is actually a challenging thing. But that, you've been able to make it this far, and I think that you would be up for the task. So, you want to state your conclusion and recommendations unambiguously. Well, I always want to highlight that people have the autonomy of doing what they choose to do. The medicines for tobacco use disorder include nicotine replacement therapy, bupropion, and varenicline. The brand names for these are things like Nicorette or Nicoderm. Bupropion goes by the name Zyban when it's used for smoking cessation, and varenicline goes by the trade name Chantix. So if you've heard of Chantix, Zyban, Nicoderm, or Nicotrol, those are Nicorette. Those are all, that's all included. But these are just like the 3 molecules: nicotine, bupropion, and varenicline. They can be delivered in a bunch of different ways, but those are the 3 sort of molecules that have been shown to be effective for tobacco use disorder. So I'm prescribing you a patch to help you quit smoking. Please wear it over your mouth. The patches comes in 7s, 14s, 21s, and 28s. They're over the counter. I recommend that people don't wear them overnight. They can cause nightmares, but to have it at the bedside to put on first thing in the morning. I also prescribe the patches with gums or lozenges. It depends on how well your teeth are. So if you're into chewing, gum. If you're into just kind of swirling the lozenge on your cheek, then the lozenges. There's also inhalers and nasal sprays, but those are available by prescription only. Bupropion, again, goes by the trade name Zyban for smoking or Wellbutrin for depression. Most people take it. It's a once-time-a-day medicine for most people. It can cause insomnia and jitter, so I recommend that people take it earlier in the day. And then varenicline, which is Chantix. It's highly effective. In fact, it's as effective as combination NRT. If you just took one, just the patch or just the gum, or if you took just one form of NRT, varenicline does outperform those forms of nicotine replacement therapy. But when you combine different formats of NRT in one individual, it's sort of you get efficacy that approaches that what you get with varenicline. So it's highly effective. Also pretty expensive, but covered on Medi-Cal. And then group therapies. So group therapies. You can have professional or peer group therapies. It engages in problem solving because, again, people who are unlearning smoking are, looking to engage in, like, how do I unlearn this? And what have you found to be effective? And what haven't you found to be effective? They're oftentimes paired with wellness and teaching programs. Group therapies don't oftentimes have a particularly firm commitment because, like, you could miss a group and the group can still happen, right? There's actually, talking about 12-step, Nicotine Anonymous, right, is a different kind of NA than we usually think of Narcotics Anonymous. But Nicotine Anonymous, there are plenty of smokers. In fact, when I was in training, one of my patients ran a Nicotine Anonymous group. He had successfully quit. He had schizophrenia, and he wanted to help people in mental health treatment quit smoking. Then there's individualized therapy, which is personalized, but there's less peer support involved. There's a variety of mindfulness and meditation approaches, telephone counseling. There's online manual treatments that haven't been that have some promising early studies. They haven't been really fully validated yet. Online therapy, but I know there's a whole bunch of treatments that are likely to be successful. So I mentioned sort of the statewide quit line. If anyone is from out of state, there is a national, smokefree.gov is a national website that will link you to your state quit line, nicotineanonymous.org. UCSF has a whole smoking cessation leadership group up there. So I don't recommend light cigarettes or quote-unquote natural cigarettes. I don't recommend smokeless tobacco, such as snus or chew or other types of tobacco products, because they're actually just as habit-forming, and you get just a different range of cancers. But the truth is that smokeless tobacco has not necessarily been associated with successful quit, and I don't recommend e-cigarettes. Right? I think there's now pretty good evidence that e-cigarettes are not associated with successful quitting, and instead use, if you want to use a medicine, use one of the 3 medicines that have been FDA approved for that purpose, and you can try to combine, if you'd like, you can combine types of NRT and with, bupropion, and then take advantage of the behavioral counseling. I think the key to smoking cessation is persistence. Right, because people are not, I think, I'm thinking of yesterday, like I had an appointment with 2 patients who were smokers yesterday. They weren't ready to quit right then, but the fact that we established a relationship and a rapport, and now that we're engaged, that ideally I will be there for them when they're ready. So I think I have 1 minute left, and yeah, and so what questions do you have, if any?
I just want to mention that also the American Lung Association has a pretty good program for smoking cessation. It's freedom from smoking. It's a 7-week, 8-session class, and it's completely free. So there's a lot of entities that are providing it for free as well.
The comment was, just for the folks that are telecasting, was that the American Lung Association, it's called Smoke Free? Freedom from Smoking. Freedom from Smoking runs a, you said 7-session?
It's an 8-session, 7-week.
Okay. 8-session, 7-week program that is completely free to help support smoking cessation in active smokers. Yes?
Thank you so much for this great episode. The second time I tried to special in the past, it was so long ago that we got to free. And I'm just wondering, I don't even know what to talk about, that works for me. That made me sad that I didn't think for example.
Yeah, the comment was from an audience member who was a pack-a-day smoker for a long time, but was able to stop smoking with the help of a nicotine patch. And at the time that she used the nicotine patch, it was by prescription only and therefore covered by her insurance. And that now it's over the counter, would that threaten the potential pathway that you took advantage of? Nicotine replacement therapy is still covered by insurance if it's prescribed. So over the counter is like an additional avenue through which you can access nicotine replacement therapy, and you have to pay for it. But if you have a prescription, insurance will cover it. Yeah. Oh, yes.
Good presentation, thank you. I'm wondering if there's any new research coming out about the idea that I've heard this from a lot of patients that use the cannabis is actually healthier than smoking, and using that as a smoking cessation tool.
So the comment was, what about comments that come from, I'm presuming folks in the community, around transitioning from smoking tobacco products to smoking cannabis products, and that cannabis might be helpful for smoking cessation. I'll tell you, I have yet to see any literature supporting that smoking cannabis helps people stop smoke cigarettes. In a way that both of those substances affect your brain chemistry, nicotine works on a completely separate set of receptors than the cannabinoids or the things that our marijuana does. And while people report, you get anecdotes of all kinds of things that are helpful for smoking cessation. Standing on my head was helpful for smoking cessation. You hear some people say, right? But that doesn't mean that that is a sort of a treatment that has been shown to be replicatively efficacious. So I've yet to see any evidence to support that claim. That said, people make all sorts of claims around cannabis and all sorts of things that they purport cannabis to be good for. I know in medicine, we tend to want to use medicines that have been FDA approved, right? And cannabis, while there's a lot of medical claims related to cannabis, the actual plant is not an FDA approved medicine. There are FDA approved cannabinoids that have been that are available as pharmaceuticals that you can prescribe, but cannabis itself has yet to really be validated as like a medication for any particular purpose, including for smoking cessation. I think that may be my time, but thank you so much for your time and attention.
We don't have
One thing we should do is move my computer to face there. Do you want to bring it up?
yes. Next up, we're going to have a panel of community representatives that are representing some of our local community-based organizations and other folks that are serving substance abuse and mental health clients in the community. So I'd like for the panel to come up. Dr. Peter Barber, Dr. Satcher, Dr. Eileen David Satcher, and Ms. Allison Paul, and have Oh, we're getting organized. Thank you, Dr. So we're going to roll the information. And so also with our care hotline, if you sign up for their email list, they have trainings that they do online. They have a webinar coming up on smoking cessation for pregnant. So it's another resource for you.
The talks are be available. Maybe the slides, but I think it's rather hear the whole talk. And I'll send out an email to the registered people for the link.
Okay. And what we want to do in this session is we have some prepared questions for the panel. Because what we want to do is to give a picture of what life down here on the ground looks like when we're working with the substance use and mental health support population in our organization, and some of the challenges that we're facing, and just so that we have a better rounded concept of what we're looking at. Because we're serving the same patients with so many different agencies in the public health system and the state system. We're just going to see the effect of this side. Okay. So
Norma, I think it would be better if you were over
sit
there,
down. Okay.
sitting down, and you could talk into the other.
Okay. Let's start off with a brief introduction. I'd like for each one of you to tell us a little bit about your background and about your agency. How much time you've had in the field. And I'd like to say that I'm very, very excited about the panel that we were able to give this morning. We have about 125 years of experience collectively, and probably more than that if you add in my 40 years. So we got a lot of knowledge here collectively on this panel, and I'm just excited to thank you so much for taking time out of your busy schedule. And I know in this fee-for-service world that means a lot to many of you. If you're not there seeing a patient or a client, you can't bill. So thank you so much for taking the time to come here. Can we start with Dr. Cox?
Okay.
Pull the mic, please. We're recording this, like Dr. Friedman said, so you'll be able to watch it on whatever.
Okay, my name is Dr. Sandra Cox. I am a licensed marriage family therapist and a licensed educational psychologist and a former school psychologist. And I did all of that over maybe 3 decades, the same 3 decades. And I am the founder of the Coalition of Mental Health Professionals, and we are in South LA. We started our organization in 1992 on the heels of the Rodney King insurrection, and a group of psychologists, nurses, doctors, you name it, from the community, basically from the Association of Black Psychologists, came together and said, how can we help our community to heal? So we started meeting at the Paul Robeson Community Center on Vermont, which doesn't exist there anymore until just recently. But we began our services there, reaching out to the community to say, what is it we can do to help our community heal? So we hit the streets, and we did that. And we're still running the agency, the Coalition of Mental Health Professionals, and it's 26 years now.
Actually, David Hanson.
Good afternoon. I'm Dr. Jean Davis Satcher. I'm an associate professor here at Drew University. And I came back to Drew after completing the PA program in the 80s, so I'm probably one of the oldest faculty members here at the university. I am a clinician at AIDS Healthcare Foundation, and I'm also a clinician at Dusk to Dawn Urgent Care. I've been working in the area of cultural competency and cultural fluency for not since the 90s, doing work on dual diagnosis with a focus more on HIV patients and dual diagnosis.
My name is Dr. Cesar Barba. I am currently the medical director at Uma Community Clinic in South Los Angeles. I'm also faculty here at Drew and at UCLA for medical education. I've been at Uma for almost 7 years now. Uma got started out of the LA riots. Actually, it was founded first by Dr. Dume, and also it's about 2 blocks away from where the LA riots happened. And so we've been they're established for about 25 years now, or almost actually no, 20 years and change. I'll get lost in the number. So really, in regards to substance use, we've dealt with some of the issues in regards to alcohol and.
A little louder.
Oh, sorry. Usually very low. Okay. So we've been taking care of some of the old, well, not old, but, alcohol and tobacco. We actually are now entering substance use in regards to opioids, given the opioid epidemic, and we're starting to provide services for that. Dr. Hurley is actually counseling one of our physicians for that. So this is just kind of quickly what direction we're at right now.
Okay. I am very much. I probably don't need this, but I'm going to use it. I follow instructions. My name is Allison Claus, and I'm from Shields for Families. That organization, or that rehabilitation agency, was founded by 3 amazing women, in my opinion. One being Norman Tume, and that was in 27 years ago. And I've been there for 26 years. I'm what's called a lifer. I think that right now Shields is probably still one of the leading agencies in South Central Los Angeles, providing help, a range of services, from substance abuse to mental health to children's rehabilitation, you name it. We've probably done it or doing it or going to do it in the future. So, yeah, Shields, if you've not heard of Shields for Families, you really need it in the community.
Thank you. Can you tell us a little bit about the trend, any changes that you're seeing in your client base in terms of housing status, age, drug of choice?
I've been, I'm sorry. the heroin effect on the uprise. Also, younger, we have 15, 16, 17 that are actually straight out addicted to meth. So that's a problem, because, you want to stop them early, but when it's so young, it can be challenging. But heroin is bad. Okay.
Dr. Davis?
Yes, one thing that I found in urgent care is that we're having a number of high school students that are having what they call gas parties, where they're doing nitric oxide. And the brain damage that this does can be temporary, but it can also be permanent. And these kids, they don't know what they're doing and how much it's going to impact them for the rest of their lives. Parents bring their kids to urgent care, severe headaches, can't figure out why their heads are hurting so badly. They're vomiting, they're throwing up, they have memory loss, and it's all because of these gas parties. And the bad thing about it is that adults are providing the gas at these parties. So that is a new drug that's in our community now. Okay.
So I would say that some of the big players, opioids, especially prescription opioids, has been a major issue. And everybody knows about that one just because it's so prevalent. But I think because of that, we have the return of heroin. Another thing that we see, especially when I see patients, I see them at Fremont High School Wellness Center, which is school-based health center. And one of the things I've been seeing is not necessarily the rise of marijuana, because when we talk to students, they kind of freely will tell you the marijuana use, but I think it's just so much more available and prevalent, where a lot of some of the students actually are smoking in our bathrooms, and it goes into our entire clinic. So it's just more, I guess, just rarely accessible and apparent. I don't really think that the amount of marijuana use has really gone up, but then again, there's also, since the legalization, there's so many different forms of it, edibles, and that's becoming an issue.
In my community, South LA, 92nd and Broadway, what we are seeing more than anything is an epidemic with marijuana. In our block and a half, there are 5, that's right, marijuana dispensaries, 5 of them, 2 next door to each other, one across the street from me, one that was up the block, and another one which used to be a alcohol treatment center, and they are marijuana dispensaries. So we are seeing these young people trying to cross the street when the cops closed one down and they didn't know that, and then they're trying to get across the street to the other one. They will be a casualty very quickly, and they're causing all kinds of traffic issues, and I haven't seen not one person in our area of South LA smoking an e-cigarette. I see that when I go in the West Side, when I go to Beverly Hills or areas like that. I don't see that over here, but marijuana is everywhere.
Mm-hmm. And I think, I mentioned cigarettes, but like Dr. Hurley said, populations that we're dealing with that are firmly addicted, they're still smoking too. How can community treatment resources help with the alcohol and drug use disorder continued explosion in our community, putting a direction, a little spin on smoking cessation? Does your agency offer smoking cessation? Is that something part of the plan? Yes or no? And let's talk about that a little bit.
Yeah, for AHF, yes. Part of our evaluation for all the new patients, it talks about substance abuse. The first substance is listed is tobacco. And it says, do you smoke tobacco? Do you use a smokeless tobacco? And they want to know how much you smoke, how long you've been smoking, are you exposed to secondhand smoke? All that information is there. And I brought along with me my my social worker from AHS, Erica, and we sat down to talk about the importance of smoking cessation in the HIV community. Because we have to remember when we talk about all comorbidities, smoking makes it worse, okay? And we don't want to acknowledge, the importance of smoking cessation, but if you think about it, we talk about emphysema, cancer, chronic bronchitis, coughing, and the increase of asthma in our children because of the secondhand smoke. And the commercial that I love the most is where there's no smoking in this particular apartment where the child lives, but smoke comes through the ventilation from the next door neighbor. So it's really, really important that we address smoking because it's impacting our community adversely and impacting our children.
I think Dr. earlier mentioned how if you incorporate smoking cessation with drug treatment, it does have a higher level of success. We did have the program in one of our outpatient programs. It was extremely successful. Of course, on the we gave them incentives. They would earn, dollars to go to the store, and that's the smoking cessation that UCLA set up for them, which has beautiful baby clothes and baby goods. And these women literally were in drug treatment, trying to get over whatever addiction they were on, but realizing that when they went to those anonymous meetings, that's all you see, the room is full of smoke, and they're drinking coffee. And so they're actually addicted themselves to more substances. Yeah. But our program was hugely successful, and UCLA, ran in. So it ended, but at the time we had it, it was extremely successful, and I saw a lot of women to this day still don't smoke cigarettes because they taught them the importance of smoking while you're pregnant and not smoking while you're pregnant, secondhand smoking, how that affects your home. So, yeah.
One thing that I've noticed, for 10 years, we ran the mental health services at a facility called the Raymond and Odessa Cox Villas on Figueroa and 92nd Street. And that was affordable housing for people with a history of chronic mental illness, and most of them had substance abuse problems. And the one thing that I had not worked in that type of environment before then, and I noticed that just about 95% of the people who lived in that building smoked constantly. They had other issues too, drug abuse, and but I had not seen that many smokers before in my life. Where our office is now, it is a drug-free workplace. It had to, in order for us to get the city grant that we had to make sure that it was drug-free. The clients we have, we serve people who are coming for our anger management, domestic violence, sex offender, parenting, and individual group and family therapy. And it's not been an issue. We have one staff member that smokes, but he's not allowed to smoke in the building or 100 feet next to the office. So it's not really a problem with the community that we're serving now as much as it was when we were serving the chronically mentally ill who were recently homeless.
So I think one of the crucial things which Dr. David Satcher mentioned is integrating your kind of substance use screening into your, nowadays everybody has electronic medical records, so making sure that's in there. It's an alert, so it tracks, it has your support staff instantly ask those questions. One of the things that we've done in UMA is take it a step further with integrating like expert to screening, brief intervention, and referral treatment into our EMR and some other tools to make it easier for access, and it's electronic. And because of that, we, moving further into kind of substance use issues, we hired a substance use counselor on staff. But before that, one of the crucial things that I always I think more and more community clinics are doing is integrating behavioral health with primary care clinics, because they really do. I mean, if you're not healthy mentally, then you're not really healthy as a whole. So I think, we all understand how important the mind is in treating everything we do and how it affects everything we do. So I think have those two kind of, when you talk about medical homes, it's really important to have everything in-house as much as you can, because you're treating the person entirely and not having to refer them out. And given that, our patient population has issues sometimes with transportation and getting around, and that they have to travel to several areas, I think it creates a lot of barriers, and we're trying to reduce some amount of barriers. So that's some of the things that, us and some of the other community clinics have been doing.
Okay, thank you. Most of the time I think in community-based organizations, I was working with the money. So I'm going to ask this question because I know a lot of times it cuts to the core of what we are able to do, regardless of what we want to do. In substance use disorders services, mental health contracts, is smoking cessation treatment in itself available service?
Yeah, it is. I have a code for you. The code is 99407 and 99406.
For medical.
For medical.
Those are the CPT codes.
CPT code. And also, when you connect those to things like chronic bronchitis, asthma, and so on and so forth, you'll find that you will surely get paid. But it's important that you check with Medicare, Medi-Cal for each individual patient, because we know how insurance goes. Sometimes it's covered with Medi-Medi, other times it's just covered with straight Medi-Cal, and some private insurance will and will not cover it. But that's the CPT code for the billing. Can you repeat it? It's 99407 and 99406.
Right, and then there's even more, it gets really complicated because when you're talking about coding, there's even more codes if you just screen and intervention. So one of the things that we do is create templates. So if you are in the middle of a visit and all of a sudden you're talking about substance use, you have this quick template you just put in, and it has all the codes and, standard things that they do. So it helps your providers kind of be more efficient, and then also helps the organization capture the coding, the appropriate coding, so you can actually bill, and actually your quality measures also improve.
Are these drug medical useful for drug medical as well?
Correct.
Because they're not listed on the code list that we get from substance use prevention and control.
I
don't know if they exist, but not exist.
Yeah.
But they're not listed as one of the CPT codes.
Okay, for
it was explained to me just yesterday, because I had to look this up twice, was that you had to have another, like if your diagnosis was heroin abuse or whatever, then and you were a smoker, then they would then treat the smoking and do some smoking cessation with you, but that you couldn't do it by itself. So I'm going to say
yeah, and I can.
Does not have tobacco listed as a primary substance use disorder.
Right, and the contracts that SASE issues, I know that that's not one of the codes that the contracted agencies are able to bill for. So unless you connect it to some other, and it gets to be a real issue, because now it has to be medically necessary. But we know the consequences of smoking. So this is an opportunity for advocacy to see if we can get that included in our contracts, because it's a problem. It's a problem, and if you go to the treatment agency, it's a problem in terms of programming. You have a heavy smoker who needs to be in group, but they can't stay in there. They got to go outside and have a cigarette, or they got to start cutting up, and your whole group is going to be disorganized. So, but then they have to go so many feet away from the building in order to smoke. And so it's a disruption in the services and even trying to treat those more severe substance abuse and mental health disorders. So just a point, just an area for some advocacy possibly in order to get those codes included in your contract so that you can't bill for them. And what about billing in terms of, okay, if you have a pregnant woman or you talked about the co-occurring disorders, you can bill that way.
So I think when it comes into like you have concomitant disorders going on and stuff, I think there are a lot of times where you won't get billed for it, but some of the insurance companies will give you incentives to make sure that you're screening and treating people. And so those don't come directly as a billing, but they'll come in as incentives later saying, oh, you screened about this percentage of people and you actually were able to refer them to treatment or give them some intervention. And so then they give you kind of credit. There's incentives tied to that, if that makes sense.
Okay.
Because we only have the staffing contract now, and it's gotten so convoluted. It's really, really hard to assist women who are in outpatient treatment now, unless you're in inpatient treatment. The outpatient treatment is almost non-existent, but we just have to keep being creative, you know what I mean, and to assist these women because they need the services.
Our agency is not a Medi-Cal agency, so our clients pay using a sliding scale, or we bill the State of California Victims of Crime Board. And getting any money out of them is hard. Even though what funds that Victims of Crime Board is when someone is arrested for a victim of crime, in order for them to get out of jail, they have to pay like $300, $500. And that's the fund to fund the program for the State of California. But the agencies who service that population almost have to go in there and turn the joint out.
Okay. Allison, you started talking a little bit about some challenges. Can all of you, because I kind of know, the various arenas that you're working in, will you talk a little bit about the major changes that have occurred primarily over the last couple of years regarding safety net rendered treatment in Los Angeles County, particularly in South LA, and how this is affecting your agency and your clients/patients?
Well, where do I start? I mean, you have other people on the panel, so I gotta let them speak. But the challenges at this point are overwhelming. I think that, just in my opinion, agencies like Shield for Families, and I'm watching the other agencies struggle. Carla is doing well because they have a large inpatient facility. They do some outpatient, but most of their services are based on their inpatient clients. But I don't see outpatient surviving under this contract for too much longer. There's too many challenges. There's too many non-billable services that they need in order to, to get through this journey. If you come into treatment and you say, I don't have housing, I don't have transportation, just on and on. And this has nothing to do with the fact that you, smoking or shooting up or taking pills every day. It does, but it doesn't. These are all the other services you need. Plus, you have 4 kids, under the ages of 18. When it's becoming, when you cannot treat you can treat them, but you won't get paid. You can't, there's no way, there's nothing to bill it under because you won't get paid, not under this existing staffing contract or my agency. So.
Yeah, and I think what you're talking about is that we used to have a large pool of funds to use for perinatal treatment services. And specifically, that's how Shields got started. We were working with Dr. Excelina Bean, who was head of neonatology at King Drew at the hospital. And in 1989, we're having like 1,200 babies a year being born prenatally exposed to drugs. So we were able to do some advocacy with Yvonne Burke at the state, and we got monies to come down to 4 county hospitals to set up perinatal treatment programs. And after that, we got money from the feds, and we got a commitment from the state that they would keep the federal money going afterwards. Well, the state money is a line item now. It comes to the county, but it's not being used for perinatal services like it used to be. So there's just a lot of changes, for whatever reason, the county felt that this was the best way to go. We're starting to see the fallout and the results of that, and so we're hoping, something can happen.
It has to change. It's not not gonna last, so it's not for us, not exactly.
It's gonna.
Dr. Barber?
Yeah, I think, what we're talking about here is sustainability of programs, right? So I think a lot of the issues sometimes arise when we have grants and we're doing really well with the grants, but then the grants run out or we're not renewed. So I think that causes a big issue, especially when we're talking about reimbursements, right? So, you can't continue a program if you don't have the funds or resources to do it. So kind of keeping the sustainability is always a crucial issue to try to make sure that the intervention you're doing continue. Sometimes what we see is, our uninsured population, there's certain medications that aren't available to them, like our uninsured population can't get Chantix, and we saw that how effective Chantix can really be. And then I think we already talked about reimbursements. I would just say I think that's just the quick things that kind of come to mind.
I see it as a vast wasteland at this point. There's just no money on the street, or very little that's coming down. And it's been going on, certainly, for the last year. And I haven't heard of any grants or funding sources. We got, a year and a half ago, we got a grant from AIDS Healthcare Foundation. Thanks to Professor Cynthia Davis. So I want to thank you publicly. Her organization and our agency worked together it's almost a decade ago on an AIDS project that we did with the prisoners paroling out of the state prisons with HIV and AIDS. And so our agency went up and met with, went to wherever they were, all over the state, to the prisons, and met with these guys who were paroling out and helped them to get back into the system, housing, food, where to get their medical services. And so, and then AH Health Foundation came through again for us in a project that we just ended. And it's amazing the work they've done worldwide based on what I've seen that they have presented to us. And it helped us to reach out to the community in a new way. I haven't really seen very much funding coming down. Opioids, I know it's a hot issue coming out of D.C., but that's not helping us on a daily basis. And I forget that proposition that we voted for about 10 years ago, and they wanted everybody to vote for it because money was going to be given to middle. Huh?
Was it an HSA?
No, I can't remember now. But it was a funding source to fund mental health services in the state of California.
Okay. Mental Health Services Act, MHSA.
Okay, what was the number?
Proposition, was it a 90-something as well? Proposition, that money still billionaire's tax.
Yeah, that's the one. But we're not seeing that money come down to this community to help.
Billionaires are keeping their money.
Yeah.
Well, no, when it gets to the county, Dr. Hurley, can you speak to that? Don't get under the desk. I see you back there. When it gets to the county, what happens with the MHSA money now? It used to be pretty visible, and you could do things that you can't do in your standard mental health contracts, and now they're asking what happened to that money because the money is still being collected.
Yeah. So the department, and let me get in front of the speaker.
Okay, do, please.
The people listening at home can hear. So the department still offers MHSA money. In fact, the MHSA revenues, as to your point, are still coming in aggressively. The internal department leadership who are overseeing that money have recently gone through transitions. We have a new director who's setting sort of ongoing directions for the organization. I will tell you, I had a meeting, because I'm on the, part of the leadership of DMA. I've had a meeting with them around using this money for smoking cessation, and they're fully on board with that. I have ideas around how the county-operated clinics can leverage MHSA money to cover some smoking cessation services that just are hard to bill, you know, through existing Medi-Cal mental health funding streams. But there's no reason that a contract agency wouldn't be able to do that as well. And to that point, actually, MHSA put out a notice to our contractors to say if you have training needs, not necessarily service delivery needs, but if you have training needs around certain topics, I know we are looking to spend down MHSA money by the end of the fiscal year, which is June 30th. And anything between now and then, I know Dr. Inna Stoneberg over the next month would be totally open to entertaining any proposals. And this won't be the only opportunity, right? There will be opportunities for contract agencies to be able to approach DMH department leadership around using MHSA dollars in exactly the way you described. So in other words, MHSA continues to be there and continues to be an avenue to be able to support many of these services that just, you know, a lot of what this panel has talked about is the fragmentation in our county and how funding streams aren't really aligned around, well, the realities of our communities. And MHSA really is there to help support services for people, you know, certainly outside of any incarcerated settings or any involuntary settings where people really can get the services they need.
Thank you.
Yep.
Okay, so just got a couple more minutes. We'll go a couple more questions too. Have any of your organizations previously partnered with academic or other research-oriented institutions? And if so, tell us about it.
I think at one point we had done something with USC on smoking cessation, but I don't remember the details. And I think it was just more of a kind of general resource guide. But unfortunately, that was a while ago, and it's not, we're not using it right now, or it's not active.
I know that we have worked with UCLA, USC, Columbia Hill. They've all come out and done different research projects on client sensitivity, client recidivism, and a few more studies. Like you said, we haven't had any in the past. I would say maybe the last one I remember was maybe 3 years ago. But they were there for quite a while, for years. I think we found but we have invited them into our programs to, research and come to some of the conclusions that we're probably reading about now, our small population of people. But, that seems not to be happening right now.
Okay.
AHF, as you heard,
There's
a lot of work in the community with universities. And we're now going to start our Liver Institute again, and I hope that'll be a great collaboration with your university.
You don't have to respond to
Only
everything.
thing I can say is ditto on AHF, because that's what helped us get through the last 18 months. And I'm glad, we can put our boots on the ground because of us being subsidized by that program. And it's sure, we all know that is a great need in this community.
I'd like to say something also as a Drew University faculty. I've worked with Shields forever and a day, and I've worked with Dr. Cox forever and a day. And so these relationships are deep. They're very, very deep, and they're long-standing. And we will continue to work together towards the betterment of our community.
And I'd like to say I work with UCLA's Clinical Translation Science Institute, and the community engagement program has a consultation division where if community organizations have something they want to research, they want to partner with an institution, they can contact that program, and they will see if there are researchers that are doing something around in that area, if they might be interested in doing something. And a lot of times researchers are interested in looking at particular topics, but they need a partner in the community. So there are still those opportunities. I think what I've seen happen over the years is that the CBOs, they're just so doggone busy trying to keep the money coming in the door, keep the clients taken care of, that seems like that's taking away time from what they need to do. But, you know, the meeting of the minds can happen with the researchers where what they're doing can be beneficial to you and to them. Just have to speak up when you go into partnership with them from the beginning. If you need extra money, they want to come on Saturdays to do something, you say, look, we got to have security here, we got to have the lights on, we got to have the gas on. You need to give us some money to help us pay for these extra expenses so that it's not always on your back. But there are ways, and if any of you are interested in that, I can talk with you afterwards and get you connected, get you more information.
I reached out recently to all the local universities simply because of the fact that our agency, the demographics in our of our community has changed. It's more so, it's over 78% Latino, and many of which are monolingual. And so I reached out to all of the universities locally, trying to recruit a bilingual, biliterate, English, Spanish only, no other languages, just those languages. That's the language, one or two languages in our community, English and Spanish. And we're looking for an LCSW or LMFT or an associate MFT. And this is a great need, so I have sent emails, posted job announcements. This is what we need, so if you guys hear me, please, if you have somebody who is competent in the areas I mentioned, please have them give me a call.
That was like my last question I wanted to ask them. What are some of the current challenges that you're facing today, including advocacy?
Yeah, I think Carla could talk.
Dr. Davis, yes.
I just wanted to say that the university has a committee called the Clinical and Community Programs Committee. And Lisa is the co-chair of that committee. So we try to focus on bringing in clinical and community programs within the university so we can have that ongoing collaboration.
I think, you were saying that staffing issues. I think that's, the demographics have been changed. For example, and so I think, fulfilling the needs of the community, especially when we're talking about monolingual Spanish speakers, is challenging because you try to provide culturally sensitive counseling and so in a lot of situations, and you don't have those resources to be able to do that. So that's a big barrier at times.
It has been challenging finding bilingual staff for whatever reason, I'm not sure. It's different because it never was before, and now that you need bilingual staff, we can't find it. So.
Yes, I think we're probably not preparing them as the numbers that we need to. But I can tell you one of the things that one of the communities programs, one of the only CDOs is Black Health Foundation. They grew their own. They hired the Spanish teacher that we had for a while. She's been there for years, and people that can barely say buenos dias, they are doing treatment. These are doctors, and they are fluent. They become fluent over time. But it has to be a commitment by the agency that you're going to train, and you're going to train well. And they've done it. They've been doing it for years. Thank you all so much.
Give the panel hand, Norma and Aaron, organizing this.
I'm Jamaican today. I have many hats.
Next, we have coming to present two students who are part of our basic science laboratory team. First up is Brianna Lopez, who is a MDS candidate for right now. And just give us a little bit about yourself, and then you can go right to your presentation, because I know you have to go back to class. Thank you.
Okay. Hi, everyone. Can you hear me? Yeah, okay. My name Brianna Lopez. I am a Master's of Science in Biomedical Sciences candidate here at Charles R. Drew University. I went to UCLA. I got a degree in Bachelor of Science in Anthropology. And I hope to go to medical school. I'm applying this summer. And that's a little bit about me. I'm from Fresno, California. So, yeah, that's me. Okay, so today I'm going to talk about African American triple negative breast cancer, what it is, how it happens, and how it spreads. So my objectives for today will be to provide an introduction to breast cancer, describe African American triple negative breast cancer, list the risk factors for African American triple negative breast cancer, discuss the harmful effects of nicotine on African American triple negative breast cancer, and how African American triple negative breast cancer metastasizes, which means it spreads throughout the body. So breast cancer, cancer is the process of which affected cells multiply and potentially spread throughout the body. Tumor growth occurs when cells divide in a localized area. And there are, do I have a?
Go over to my computer, just to,
Oh.
yeah, there you go.
Oh, okay. So, and there are two types of breast cancer. There's ductal, which is in the milk ducts, and then there's lobular, which occurs in this area here. And there's in situ, which means that it stays within that area and grows within that area, or there's invasive, which is the metastatic, which it starts to divide in that area, but then it starts to spread throughout the body. And then in 2018, they estimate approximately 266,000 cases of invasive breast cancer are going to be diagnosed in women within the U.S., and a little under 64,000 non-invasive breast cancer diagnoses. So this is how breast cancer spreads throughout the body. So what happens first is you have a bad cell, as I would call it, and it mutates, so it's an unhealthy cell that starts to go bad, and then that bad cell will start to divide. And as it divides, it grows, and then it kind of gets too big for its area of where it's like kind of situated, where it made its home. So then it'll find the bloodstream, and it'll kind of seep into the bloodstream. And as it goes throughout the bloodstream, that's when it goes into other areas of the body, and that's when it goes into different organs, maybe the bone, maybe your brain, maybe lungs, liver. So that's kind of how it grows and metastasizes throughout the body. So low prevalence and high mortality in African American triple negative breast cancer. So among breast cancer in general, only 12% of cases are triple negative breast cancer, and Caucasian women are actually diagnosed more with this type of cancer. However, despite the low rates in African American women, they have poorer outcomes. So they have a higher mortality, they're getting this cancer at younger ages, and there's no targeted therapies for this type of cancer. And African American triple negative breast cancer is actually found to persist despite socioeconomic status, which is leading us to believe that the biological component is a very important factor in why it has this low incidence but high mortality. So what is the significance of studying African American triple negative breast cancer? We want to better understand how African American triple negative breast cancer develops, understand the underlying mechanisms, determine the risk factors of African American triple negative breast cancer, and interpretative measures. And of course, at the end of the day, what's important is to lead to better health outcomes within our communities. So what are the risk factors for breast cancer? We see things that cannot change are our race, our gender, our genetics, our age, but what we can control are exercising, food, not consuming alcohol, not having a high-fat diet, and as we're talking about today, smoking. So smoking and its health risks. So smoking has attributed to almost 35% of cancer-related deaths in men and about 25% of cancer-related deaths in women. There are approximately 5,000 compounds and 50 carcinogens in traditional cigarettes. And then nicotine, which is found in the tobacco leaves and is also isolated in electronic nicotine delivery systems, contributes to the addictive properties of smoking, genetic mutations, and tumor-promoting effects. So what are ENDS? So what are these electronic nicotine device delivery systems? They're also known as vapes, as you may have heard. Juuls, that's a new thing on the market that kids are getting into. They're battery-powered devices with a tank containing nicotine and a propylene glycol solution. And this vape, or this ENDS, what it does is it heats that nicotine vapor, or that nicotine solution, and it vaporizes. It goes into your respiratory tract and then goes into the bloodstream. So are ENDS harmful? So the American Association for Cancer Research and the American Society for Clinical Oncology both recognize ENDS can have the same detrimental effects as normal tobacco use, whether that's traditional cigarettes or chewing tobacco. ENDS is also shown to constrict the peripheral pathways, the peripheral airways, and possibly as a result of the irritant effects of the propylene glycol and nicotine. That's what causes the constriction. And then when combined with a high-fat diet, ENDS have increased the development of a fatty liver, which was actually seen in our lab by the principal investigator, Dr. Hassan. So ENDS are not good for you. So metastasis in African-American triple-negative breast cancer, moving to that again. So of all cancer-associated mortalities, 90% of them were contributed to metastasis. And women with triple-negative breast cancer were 4 times more likely to have visceral metastasis within the 5 years of their cancer diagnosis. So my research project, what am I doing in the lab? So I want to see how nicotine exposure mutates normal cells. If I get a normal breast tissue or a normal breast cell, if I expose that to nicotine, how does that cause carcinogenic effects? Will it cause carcinogenic effects? And then also I want to understand how African-American triple-negative breast cancer metastasizes. What are the properties that enhance its metastasis, and if ENDS exposure has an effect? So with my first experiment, what I have been doing is I've been treating cells, normal mammary epithelial cells, with nicotine, and I'm seeing if I treat them over time, like for cells, 2 weeks is a long time. So if I treat it for a long time, does that mimic that long-term exposure to nicotine and smoking? And will that have any effects on the cancer properties? So then I'll analyze those results and see. And I have done that so far, and it does show that exposing these cells to nicotine does have these effects. And then my second experiment, I want to allow tumor growth of African-American triple-negative breast cancer cell line in immune-suppressed mice. So what we do is we allow these tumors to grow in these mice of a known African-American triple-negative breast cancer cell line. And as it grows, we image and track the movement of these cancer cells and see where they metastasize. So this is something that they've done on Caucasian triple-negative breast cancer, but we've never seen it in the literature of it being done on African-American triple-negative breast cancer. And as we know, it acts differently. We see that higher mortality. What leads to that rapid metastasis, and what leads to the higher mortality? And then we want to expose these mice to the electronic nicotine delivery systems. And we want to see, does that change the metastasis? Is nicotine, is smoking, does that cause even more metastasis in African-American triple-negative breast cancer? And what is the clinical significance? So why are we studying this? Again, it's a health disparity is an issue, and it needs to be addressed in research to understand why African-American women are having such high mortality when compared to the Caucasian population, or any other race for that matter. And precision medicine through targeted treatments can potentially decrease the mortality rates. So this is a very understudied part in the research, and we want to know more about it. It's important. It's important for our community members, and it's important for us to understand. the issue that's going on. Questions? Oh, yeah. Oh, yeah.
Yeah, so now what you're saying is that it's not down in cancer, at least areas that are highlighted.
Yeah, so this shows, okay, so she was asking if the areas shown is showing the metastasis, and if this is where it started to grow and move towards. Yeah, so that's what it's showing. So it's showing that it started here, and now it's growing here, here, here. So you do see it growing. And then, yeah, go ahead.
So I've heard different arguments around this, but you use the word vaporizing when it comes to the ends. And I've actually, I know like Dr. Hurley, I've actually heard the other term, which is aerosol.
Okay.
And the people that say that vaporizing isn't the actual term we should use, say that it's because it's a water base.
Okay.
And what ends actually has is it's chemical that is put into particulates. And vaporizing is a term that I guess a lot of companies use to make it seem safer. So I'm wondering if there's a reason that you use vaporizing as opposed to aerosol.
I feel like I've seen vaporizing more often. Maybe that's probably why I use the term. And I haven't really heard aerosols.
I think you are correct that the proper term is aerosol, but because everybody uses vaping, vaping, we also use it in our thoughts.
Yeah, just so, because I feel like everyone knows vape, not aerosols. So that's what I would say. Hi, yes.
Secondhand smoke, how is that linked to African American triple-negative breast cancer versus women who are smoking versus women who are exposed to secondhand smoke?
So
and what are the rates in terms of incidence and prevalence? You say there's low incidence but high morbidity among African American women. What are the rates compared to Caucasian women?
Okay. So the first question was about secondhand smoke in African American triple-negative breast cancer. So we haven't studied the secondhand smoke in African American triple-negative breast cancer, but we are studying secondhand smoke and its effects in general. And I've also read in other literature that it does have a pretty big effect on just cancer in general, secondhand smoke.
Well, secondhand smoke is a carcinogen, so therefore it's linked to any of the diseases connected to cancer. So the exposure of secondhand smoke, the continued smoke, exposure to secondhand smoke will result in some effects, especially long-term.
Yeah.
Long-term. And that's what they're, as one of the doctors mentioned, they also ask, whether they smoke and they use tobacco and if they're exposed to secondhand smoke, because they're seeing all of these results connected to long-term effects such as cancer and other, chronic diseases as well.
So, and then in regards to the lower rates and the higher mortality, so what we do see is it's about a 10% lower rate in African American women, and we do see that it's usually Caucasian women will get breast cancer around in their 60s, and we're seeing it lower in the 55 to 58 range for African American women. And then as far as the mortality rates, I believe it was from the last research that I read, it's upwards of 42%, that more mortality rate. So it is pretty concerning.
Thank you, Brianna.
Thank you.
I'd love to get a chance to have our students participate like this.
Good job.
Great. And our last presenter, hope you can hear the rest of him. It's only a few minutes now. Is another MBS candidate for this year, David Nathan.
Good afternoon, everyone.
All right, so my name is David Nathan. Can y'all hear me? My name is David Nathan. I was born in Oklahoma, raised in Alabama, and I graduated from the Xavier University of Louisiana with a Bachelor of Science in Biology, minor in Chemistry, and I'm a current 2018 Master of Science in Biomedical Science candidate, just like Brianna. Normally, I don't have a problem with speaking low, so I don't know what's going on here. All right. All right, so we just have a few learning objectives today. What is nicotine? What does it do? We're going to list 3 characteristics of nicotine. Then we'll talk about the allure of electronic nicotine delivery systems, which is just electronic cigarettes. And then also we'll talk about how nicotine affects the body, namely the heart, blood vessels, and the liver. Okay, so what is nicotine? Nicotine is a stimulant. It imitates the action of acetylcholine. And acetylcholine is an important molecule in the body. It has a lot of different functions. It deals with memory, muscle movement, appetite, along with a lot of other functions in the body. And so dependency occurs because when nicotine is exposed to these cells, it causes a release of dopamine, which they call the pleasure molecule. And so what ends up happening is, so when an individual will vape or smoke, they'll have, the body won't process all of the nicotine. There'll still be some nicotine in the body, and it'll cause kind of this continual release of dopamine, the pleasure molecule. And then from that, people get used to that feeling, so that whenever they don't smoke, they feel like they need to go back to the, whether it be cigarettes or nicotine, and kind of get that pleasurable feeling. And then so what also happens is when you have an individual that, maybe may smoke a pack a day or may vape upwards of 20 to 30 times a day, the body ends up creating more nicotinic receptors, which are the receptors that respond to the nicotine and causes the release of dopamine. And so the individual ends up needing to consume, or I guess, vape or smoke more nicotinic products to get the same feeling. Okay, so the allure of electronic nicotine delivery systems. It's very customizable, it's multi-flavored, it's conveniently rechargeable. Somebody can be, vaping at work, and then when they get to the car, they can charge up the battery, or they have another battery, they can just pull that battery out from the charger and begin to vape. And money-wise, it's not currently subject to the California 2016 proposition tax increase, which I believe caused the unit of nicotine per product to be $2 per unit. And just to give you a practical example, mid-grade electronic cigarette starter pack would be around $39, where you'll get a couple batteries, 10 cartridges, they call it tanks, which has the nicotine liquid in it, and 10 of those. And then also, after that, it'll only be $9 for a pack of 5. And then also it has a smooth design. I mean, looking at this, it kind of simulates elegance a little bit. You can take it out, vape, and then just put it back in your pocket. Okay. There's some formatting issues going on here. So the reality of electronic nicotine delivery systems. So acetaldehyde is one of the components in electronic cigarettes. And acetaldehyde is actually a naturally occurring substance. It's in coffee and apples when they ripen. But metabolic-wise, it comes from when the body processes alcohol, and then there's a buildup of acetaldehyde, which contributes to the hangover phenomenon. So you can imagine that that's not really good to be consuming concentrations of that. And then nitrosamines is a known carcinogen. It's actually contained in latex products like balloons and condoms. And it's actually been shown through research that when injecting it into mice rectally, it can cause cancer. And then formaldehyde. Formaldehyde is also carcinogen. It's actually part of a chemical that has to do with like engine transmission. It's one of those chemicals. It's also used for embalming fluid, for preservation of tissue, and also it's in different products like this wood product here probably has some formaldehyde to preserve the structure. All right, so in this slide, I'm going to try to paint a picture with my words here. So nicotine causes a narrowing of the blood vessels. So I want to give a quick example. Let's say that all of us in here had the job to build an apartment complex which housed 40 families, and after doing all of our math, we decided that we needed our pipes to be 10 inches in width, so that the pressure in the pipes would not be too high to cause water damage to the building. But then in doing our budgeting and math, we found that we only had enough money to make the materials to have the pipes be 7 inches thick. Well, that would be a problem, right? Because we would have too much pressure in the pipes. And likewise, also because the same amount of water has to get to these families, it would be a problem. And the same with nicotine, how it causes a narrowing of the blood vessels. Well, the heart still has to pump the same amount of blood to the tissues, and it raises the blood pressure. And then increased cardiac work and elevated blood pressure and heart rate. Nicotine also causes the release of adrenaline, or epinephrine, and norepinephrine, which are just stimulants that cause the heart to pump faster. And then so blood supply deficiencies can arise because, keep in mind with point 1, you have a narrowing of the blood vessels, and we all know that, normally when we get a cut, our body has clotting factors that are supposed to help us not bleed out. But when you have a crowding of the blood cells in the arteries, it can cause them to collide more and possibly clot, which that clot will block the vessel and could block blood supply to certain tissue. And then the last point is elevated blood cholesterol. So what ends up happening is, I know actually when I grew up in the community I grew up, I noticed that long-term smokers would be a lot leaner. So what ends up happening is nicotine causes our fat cells to release free fatty acids into the bloodstream, so that we have a increased VLDL, and then that causes increased bad cholesterol. But then also from that, because you have an increase of these fatty acids, they can tend to crowd the arteries, which can cause plaque buildup. All right, I put this here because I was blessed to be in the lab with Dr. Freeman, where we have a patent on electronic cigarette chambers. So what this chamber is, this is how we expose mice to the electronic cigarette vapor to mimic the effects of electronic cigarettes. So it's supposed to be like an airtight chamber, and it's hooked up to an air supply so that when in certain intervals, it pressurizes and mimics somebody inhaling like they would when they're inhaling an electronic cigarette. And so then the vapor comes out into the airtight chamber, and you see here that there's mice here, and then they're exposed to it and they inhale. All right, so the World Health Organization says choose health, not tobacco. And unfortunately, tobacco causes over 2 million deaths from cardiovascular disease every year. So this is some echocardiographic data. It's just a measurement of heart function. We don't have to go through everything. I really just want you all to pay attention to these 3. This is what I'll go over. So LV percentage FS is just left ventricular fractional shortening. So what it's saying is, keeping in mind that the ventricle it's a chamber, so it holds the blood in a circular chamber. So this is just a measurement of when the ventricle is contracting, what percentage is it contracting. And so you see here, I really just want you to pay attention to this column and this column. Saline is representative of a non-smoker. And then Ns 2.4 is representative of an individual that uses electronic cigarettes with a 2.4% of nicotine. And so you see here with a non-smoker, it's 35 versus 27 with the individual that's a vapor. I'm having some technical difficulty. And then VCF is ventricular fractional shortening. So this is just really a measurement, a mechanistic measurement of how well the heart fibers contract whenever they do contract. And you see here at 7.1% of the total circumference or length of the fibers in a non-smoker, as opposed to 5 for an individual that uses electronic cigarettes. And then LVEF, left ventricular ejection fraction, that's just a measurement of what percentage of the blood that enters into the ventricle gets expelled to the arteries that to then go to the tissues. And you see here for a non-smoker it's 69%, whereas with a smoker it's 60%. So this is a beautiful TEM picture, transmission electron microscopy picture. And so A is representative of a non-smoker in comparison to B, C, D, and E. And what it is this tissue is sarcomeres, which is basically a heart cell complex that's responsible for contracting. And A is actually the more oval structure you see is the nucleus, which is kind of the director of the cell. It tells the cell what it needs to do. And if you can see A versus B, C, D, and E, and F, you see a lot of degradation of the nucleus in comparison to this, which is terrible because, again, this is basically the director of the cell. Now, G, H, and I is actually mitochondria, which is basically the powerhouse of the cells. It's giving the energy, it's helping generate ATP for the heart muscles to contract. And in comparison, you see some degradation here. This is being normal, non-smoker, and this being an individual that uses electronic cigarettes. Okay, so now earlier we talked about how fats can line the arteries. So what the lab ended up doing is we took a blood vessel and we kind of did a section of it, a cross section of it. And so oil red O is just a stain that helps stain triglycerides or fats. And so you can see here with saline, you kind of see less crowding of the arteries in comparison to Ns 2.4, which is representative of an individual that uses electronic cigarettes. And you can also, I don't know if you all can see, but for B, it just kind of gives you a quantitative measure of the area, and there's quite a big difference. So then now we're going to talk about the liver, because fatty liver disease is kind of a secondary effect of smoking. So again, we talked about how the nicotine can cause our fat cells to release fatty acids into the arteries, but then not all of it gets crowded into the arteries. Some of it goes to the liver. It can cause accumulation. Now this is a beautiful staining. So stage right. This one here is representative of an individual on a Western diet or a normal diet, a saline of a non-smoker. And notice you can make out, but it's kind of rather difficult to make out the fatty deposits, as opposed to stage left picture here. You see more prominent circles. These are representative of fat accumulation in the liver. And here's another picture. I'll just want to really direct your attention to these two right here. So this one here is a representative of an individual that has a high-fat diet, because sometimes your diet may be based on what's available to you and what you can afford. So an individual that has a high-fat diet but doesn't smoke, these little, the blue circles are representative of lipid droplets in the liver. And keep in mind, these two are the same magnification, but when you have an individual on a high-fat diet and nicotine, look how much larger the fat droplets are in the liver. So it worsens it. And with that, I want to thank Dr. Friedman, Ms. Mtume, and all the other members in the lab, as well as Friends Research and the California Tobacco-Related Disease Research Program. And thank you very much. Are there any questions? Which slide? Oh, sure.
What are they doing over here? Is it the same picture as just, oh, is this when they had it and this is when they had it?
Yes, ma'am. It's before the vapor release.
You can see the sort of light, the vapor is sort of pouring over where it's coming out.
So they're having up trying to get it?
Yeah.
David?
Yes, ma'am.
I've just seen a lot of commercials recently about the tobacco industry targeting young people. When you're 15,000 flavors, how easy is it for minors to get the jewels or whatever you call them? Or are people buying them, are adults buying them and giving them to the kids? Because they're saying they're smoking them in school, they're going to the bathroom and vaping and such. How easy is it for minors to get access to them?
I would say, unfortunately, it's very easy. You can buy them on Amazon. I don't think there's really any way to check if you're of age, except for to click a button and say, yes, I'm over 18. Also, they're in gas stations, Walmart.
Unless you have a way to pay your line.
Yep. All you have to do is click a button
So
and
a
say yes.
regular pack of cigarettes now is costing about $10. How much do these cost? These vaping kits?
So a starter pack is around $39, which will give you 10 cartridges and a charger and batteries. And then after that, for about 5 packs or 5 tanks, they call them, of liquid, it's only like $9. So roughly like $1.48 per cartridge.
And the cartridges last much longer because the conventional cigarette companies smoke one cigarette at a time, and then they're done with it. These you can light up for a couple minutes, put it down, light up again. So they usually last longer.
I just wanted to make a comment too about the children and stuff. I facilitate a smoking cessation group at Continuation High School, and the kids will tell me that they get it from the gas station. That if you go to the right gas station or the right smoke shop, the owner or whoever works there will give it to them. But then another thing too is some of my kids, they're 16 years old, but they hang out with a couple older kids, over 18, 20-year-olds or something like that, and then they'll buy them for them too. And a lot of these kids, like my kids that I work with, their parents know that they vape. You know, and the parents are like, well, I mean, I'd rather you do that than, you know, whatever. So, kids are getting it kicked on the tobacco store.
Is anybody introducing any kind of legislation or policy to try to protect children from vaping, knowing that the detrimental side effects is really like a gateway to cigarettes?
Right.
From what the commercials are saying.
Yeah, not that I know of. And unfortunately, the popular opinion is that they're safe because they're saying, oh, okay, so I don't have the full tobacco leaf, but that's why we have to raise awareness of the dangers of nicotine in itself.
I was just going to comment, there was a law passed in California 2 years ago, sponsored by Ed Hernandez, who actually spoke at one of our drug addiction research days, saying all tobacco products, including e-cigarettes, you have to be 21 or older to buy them in the state of California. Other states, you can be 18. You go to Blue Cigarettes or Amazon, you only have to be 18. But, you know, it's very hard to enforce this, and I think that's one of our purposes of our symposium today is talking about what we're doing to try to educate the public and gear the public about how bad these e-cigarettes are. Hopefully you guys will start back and with your students here, and you guys, everybody has the interactions with people that might be using this, get the word out that these are not so safe.
Yes, ma'am.
And my question is how long do you think it will be before bootleg versions of this will be found, will be sold to you? You know, like everything else is kind of like a illegal version of it, where some kitchen tenants will be mixing something up and selling it on the street.
I think, unfortunately, I think that's already happening now, because you have other substances that kind of mimic this, but it has THC in it as well as other things.
Well, theoretically, there isn't any policy around these devices, so it's not even so much that they're making up things or creating things. All of them are not regulated and not FDA approved and not. So that's why we see sometimes that they like blow up in your face because of the tracking process. And also things like jewels actually have been proven to have enough nicotine, or actually overabundant nicotine, to the point where they're proven to link directly to cigarette use. So, yeah.
Yes, ma'am.
They definitely go back to the community, because just like I heard say earlier, the weed stores on 97 in Broadway. However, just because you say you're 21, I personally know people under the age 21 that just still walk on the bend here. So at the end of the day, I just feel like it's more community-based, because if no one's actually going to, let's say, because I do outreach, so let's say if no one's actually going to these businesses and letting them know, hey, you guys know you still have underage people coming here to get the marijuana and the cigarettes, because it's still stores and gas stations in these communities that, that where a 16-year-old can still go to the counter and actually receive the cigarettes or the marijuana.
Unfortunately, integrity is lacking in all of our communities.
I just wanted to let you all know that I work for City Council and we started to provide enforcement in regards to understanding policy and regulation.
Yeah. And to feedback on that, the LA County Department of Public Health, the tobacco control program is releasing grants to different agencies that are going to be working on the TRL retail tobacco retail license, which is is entitled for the organization to do assessment, to work with the enforcement authorities to try to enforce that it has to be that the access to these products only to people over the age of 21. So there are multiple legislations working on this, and there is multiple programs. The thing is, it's always going to be that one friend who allows it to, buy, to have access. The parents sometimes are the ones that who do it the most. They'll be okay with it. They'll just say, oh, it's just marijuana. Or I'd rather do it you at home than you're doing it something else or doing it outside with friends.
Yeah, and so on top of that, I've been in communication with an agency called Day One, and they do a lot of that with the retail and stuff.
Yeah.
But some of their problem that they've seen is in the actual cities, so they have to bring that to the city, and the city has to say, okay, yes, let's put this tobacco retail tax on, but a lot of cities don't want it because of, I don't know about it.
Business.
Right.
Well, keep in mind that this is business. So anything that is selling is business. So there will be people lobbying for it not to pass, for it not to be regulated. Because if we try to enforce all of these legislation, either state, city, county, wherever you want to see it, there's going to be opposition because, of course, the sellers are going to go down because there's not going to be it. The youth is not going to have as much access as stuff when there is no legislation. So if we put our efforts together, I think we can get this farther.
Yes, indeed.
I just want to thank you for including information on the liver, because I think when it comes to the liver, people only think alcohol, and so I think it's efficient.
Exactly.
Yeah.
And then we can.
Those are the question, but I think this
and really getting into I like the word you use actually, the integrity, comes to this idea of having that playground, having that access to the holistic approach available. I thought the playground research was, but it's an idea where if you don't provide anything else than just that, then that's all that you really get a kick in, and it's kind of the feel good. But if you provide a playground, right, for other things to do, other kind of productive things for these individuals to take part in, to belong to, then, we all work together and they become, better versions of it.
Thank you all very much for listening to me.
I want to comment one thing. In David, in our work, the e-cigarettes without nicotine were pretty benign. It's really nicotine. So if you're going to have your kids smoke e-cigarettes, get them to use the non-nicotine one.
There's a use in it for other things.
Yeah.
They're putting the pot,
Marijuana.
a lot of these things. So in a way, we don't want to induce kids to use any of this.
And I wanted to say one last thing too. If you all have any family members or friends that are addicted to anything, whether it be nicotine-related products or anything else, I just want to encourage you to help them find other outlets and support them and bring in support from other people. There's other people in the world that care as well. Thank you very much.
Okay, we've had all of our speakers. I hope all of you have been able to glean something from this, and we thank you for your comments and input as to what we had to share. Remember to fill out the back of the first page of your packet, especially the bottom portion where it says comments. We'd like to know, what you like, what we could have done better, what we could do better next time. So thank you again.
Norma, big hand also for organizing. Good jacket. Done there before?
Probably one of our speakers.
Right.
Did you have a jacket? G. Brianna, she's coming back.